Pittsburgh, and this work was done when I was a master's student at the University of Florida. So consider this particular problem where Nancy is having a fever and she's confused which particular medication that she's gonna take. Of course, now she has a particular feature vector with all the different kinds of characteristics such as age, blood group, sugar level. Now she has a choice of taking medication A versus medication B. We can represent this particular problem with this particular causal graph where X is the features of Nancy, T is the treatment, which is like either the values of 0 and 1, and Y is the desired outcome. We wish to measure this red hat, and the question is how T is causally related to the outcome Y. This problem is fundamentally challenging because at one point of time we have only the access to one particular outcome. Consider in this case while Nancy is taking the medication B, which is like T equals to 1, and we can only observe the outcome Y equals to 1. At any point of time we don't have the access to Y0 at the same time, and we cannot be able to measure whether medication B is better than medication A. Here, Y1 is the factual outcome because we can observe it, and Y0 is called the counterfactual outcome because we cannot observe it. Now, we are living in a big data era where data can be from all the different kinds of sources, from social media to EHR to radiology reports to big medical imaging data sets. But the data can be very, very problematic. In the real world observational data sets, the confounders and the colliders, they are the problematic elements which can create different sorts of biases. Confounders are the common causes of an outcome and a treatment. Confounders are the common cause of an outcome and a treatment, and colliders are the common effect of an outcome and a treatment. Now, causal inference is predominantly challenging because of the existence of the counterfactuals. Now, we have some solutions, which can eliminate this. They are called randomized controlled trials, propensity score matching, or inverse probability treatment weighting. But they have their own sets of drawbacks. For example, randomized controlled trials, they are unethical and sometimes they are also not feasible. Whereas in propensity score matching or inverse probability treatment weighting, they are mostly linear, they mostly follow the logistic regression for the downstream estimation task. We are also living in deep learning era where our goal is to model the nonlinear treatment assignment, handle high dimensional inputs, and provide the nonlinear counterfactual predictions. In this regard, we want to present our contributions in this project. We first want to incorporate an underlying causal structure to approximate the data generation process. Next, we want to infer the latent variable using a variational autoencoder. Third, we want to generate the counterfactual outcomes using a generative adversarial network with variational information-theoretic regularization. Fourth, we want to estimate the individual treatment effect by minimizing the factual and the counterfactual outcomes both. And lastly, we want to use the doubly robust regularizer for faster convergence. Let's see the problem formulation. Here, throughout this work, we actually followed the potential outcome framework by Lubin, where we are given a set of tuples where x's are the set of covariate or the feature vectors, t are the treatments, and y is the outcomes. So this yi is the observed outcomes, and y0 and y1 are the potential outcomes for treatment t equals to 0 and t equals to 1. And our goal is to measure the individual treatment effect, or ITE, which is the difference of these two potential outcomes for a particular sample. And also in this work, we have the strong ignorability assumption, where both the potential outcomes are conditionally independent of the treatment given the set of covariates. So this is the first contribution, that is we want to incorporate this underlying causal structure, where we thought that the set of covariates are generated from 4 independent random variables, zt, zx, zyf, and zycf, for the treatment features factual and counterfactual outputs respectively. Next, this is the complete architecture of our model. Here, the VAE block aims to infer the latent codes, and the GAN block aims to generate the counterfactual outcome. So let's decode this gradually. So this is the variational autoencoder block, which we are using to infer the latent variables. In the encoder block, we want to infer the 4 latent variables zx, zt, zyf, and zycf from the observed covariate vector x. We assume that all the latent variables has a prior Gaussian distribution. Next, we define those we define the variational posteriors using the encoder of the VAE as a factorized Gaussian distribution. We learn the mean and the variances of all the Gaussian distributions using this particular encoder block, and the latent codes are then will be sampled from these variational posteriors. Lastly, this is the elbow loss function that the VAE optimizes. The first term is the reconstruction loss from the decoder, and all the remaining KL divergences will make sure that the variational posteriors should be as close as to their priors. For more details of the derivation, please go through our supplementary material. Next, we're gonna concatenate all the different latent codes to form the ZC vector, and we will feed in to the GAN to generate the factual and the counterfactual outcomes. We also aim to increase the mutual information between the learned concatenated latent code ZC and the generated output G, which is a function of the random noise and the given concatenated vector GC. However, solving this particular mutual information is intractable. So we follow the InfoGAN formulation, where we utilize an auxiliary network Q to estimate the mutual information. The complete GAN loss function is herewith. Once we learn the counterfactual outcome from the GAN, we append it to the tuple x, t, and the factual outcome. And next, we use a Tarnet model to optimize for both the counterfactual and the factual and the counterfactual outcomes. To ensure the faster convergence, we incorporated this doubly robustness formulation from Johnson et al. Traditionally, logistic regression is used to estimate this doubly robust estimation. Here, we integrate the propensity and an auxiliary network, which are all the neural networks, to estimate this doubly robust loss. Here is the complete 4-headed network to ensure the doubly robustness. We also add this propensity loss to our potential loss function that we computed earlier. And this is how we actually measure our doubly robust outcomes, pi and mu as the propensity and the auxiliary network respectively. The doubly robust loss is computed in this particular manner. And finally, we minimize the weighted combination of the potential and the doubly robust loss to optimize the network to estimate the individual treatment effect. We measure the performance matrix in terms of the error on average treatment on the treated, precision estimation of heterogeneous effect, policy risk, and average treatment effect. Now, this ATT, which is like the average treatment on the treated, and the policy risk, these two metrics are used for real-world data sets like jobs and quits, where we don't have the access to the counterfactual outcomes, whereas the precision estimation of heterogeneous effect, treatment effect, and average treatment effect are used to estimate the differences between the true causal effect and the estimated causal effect, where we have the access to the counterfactual outcomes for the simulated data set. So let's see some of our results. So this first result is on the basis of the simulated data that has been obtained from another generative model called CVE. Even though the data generation process of CVE is completely different from Dr. Vidal, which is our method, we can see that our method with the doubly robustness performs the best for estimating the error on the average treatment effect. The red plot indicates this. We also generated the data based on our model and compares the PHE metric with respect to the benign. Here also Dr. Vidal with the doubly robustness performs the best. Here also you can see that from this red plot. Lastly, we perform the same experiment to estimate the log PHE metric. Here also our method beats the baseline. Finally, for the real world data, we used IHDP, jobs and twin datasets to evaluation. We performed an ablation study and checked that Dr. Vidal with the doubly robustness loss performs the best in terms of the important matrix for all the three datasets. We also tried to estimate the marginalized factual outcomes for t equals to 0 and t equals to 1. In all the data sets, we can see that Dr. Vidal with the doubly robustness loss performs better than its non-doubly robustness variance. Finally, this is the comprehensive comparison in terms of the PHE and the policy risk of Dr. Vidal with all the different state-of-the-art models. For IHDP and jobs, our model outperforms the other model. For twins, Dr. Vidal is comparable with the other except Ganite. For twins, still Ganite is the best. This table compares the performance of Dr. Vidal with all the other models in terms of the error in average treatment effect and average treatment effect on the treated. Here also Dr. Vidal shows comparable performance with all the different state-of-the-art models. So in conclusion, we incorporated a causal graph to estimate the individual treatment effect. We utilize a VAE to infer the latent variables and a GAN to generate the counterfactual outcomes. Finally, we utilize a doubly robustness loss to the Tarnet to estimate both the factual and the counterfactual outcomes for faster convergence. Please refer to our GitHub link for the code. So these are some of the future directions where the causal graph in this problem is very simple. We can enforce some strong, strict disentanglement constraint. Instead of variational information maximization, we can use